Hello, everyone. I hope you're doing well. I'm honored to welcome you today to the American University of Beirut Global Health Institute, GHI, that hosts the Center for Research and Education in the Ecology of War that I will be referring to as CREEW. So in CREEW, we are holding today a webinar titled Bridging Research and Practice in Conflict, the Nexus of Climate, Health, and Preparedness. Today, we're honored to have with us Dr. Suha Kanj, who will deliver the first part of our webinar addressing the intersection between climate change and health in conflict settings. Dr. Kanj is a professor of medicine and the head of the Infectious Diseases Division at the American University of Beirut Medical Center. She's also the president-elect of the International Society of Antimicrobial Chemotherapy and the president of the Lebanese Society of Infectious Diseases and Clinical Microbiology. Dr. Kanj, thank you for being with us today. Thank you. This will be followed by an overview of the CREEW 2025 GHI-sponsored fellowship program, where I will address the application process for this year, and this will be followed by a 10-minute Q&A. My name is Nasreen El-Hadi, and I'm currently the manager of the Academy Division of the Global Health Institute, that is our capacity building arm. We have with us Dr. Hadil Mdakhli, who is also an associate coordinator at the Academy Division, and Ms. Sarah Ibrahim, who is a program manager of the Epidemic and Pandemic Preparedness Program, also part of the GHI team. Thank you, everyone, for joining us, and I will leave the floor to Dr. Kanj.
Thank you very much, Nasreen, for the invitation and the kind introduction. It's a pleasure to be presenting today, the first webinar in the CREEW series. So as Dr. El-Hadi mentioned, I'll be talking about bridging research and practice in conflict, the nexus of climate, health, and preparedness. So this will be the outline of my presentation. In 2023, you are all aware that the world saw the highest global temperatures in over 100,000 years. And with the climatic conditions that we are witnessing, there is an increase in climate events. These could be in the form of storms, extreme heat, floods, wildfires, or droughts. And these hazards not only lead to higher risks of fatalities from the catastrophes by themselves, but also they lead to an increase in non-communicable diseases, to infectious diseases, and to health emergencies in general. So let's examine the climate-related health impacts. WHO predicts that about 5 million additional deaths are going to be due to climate change between 2030 and 2050. And this will incur an estimated cost that will go up to around $4 billion by 2030 on an annual basis. And if we look at the climate-related health impacts, well, first, we can classify these in 4 different categories. The heat-related illnesses, and with heat waves, we know that there will be an increase in heat strokes, in episodes of dehydration, skin diseases in general, particularly among children, diarrheal illnesses, and strokes. But also there is an increased risk of non-communicable diseases. With an increase in air pollution and heat stress, we can expect an exacerbation of cardiovascular diseases, but also of particular importance is respiratory diseases, such as exacerbation of asthma attacks and chronic bronchitis. With the change in the weather and also with the increase in the tsunamis and the floods, in the earthquakes and all the climatic related disasters, we expect to see a lot of destructions, and with that comes a lot of destroyed property, death of loved ones, and all this will have particular increase in mental health and well-being. So we see a lot more emotional trauma, fear, anger, and psychiatric problems. And last but not least is the malnutrition, extreme weathers and droughts, can disrupt food supply, leading to malnutrition, particularly in low middle income countries, and particularly in countries that are under conflict. But there are also infectious diseases that we tend to experience more when we have change in climatic, in the climate. And for example, if we look at changes in temperature extremes, what happens with that, there is a geographically expanded tick activity, an expanded habitat of mosquitoes. And if we look at vector-borne infections, for example, we see much more evidence of Lyme disease, particularly in some countries in Europe, as well as the northeastern of the United States. Malaria, for example, tends to increase with climatic changes. And dengue, a viral infection that was limited to tropical countries in the past, we tend to see more and more of that in other countries, not only in the global south. And for example, a study showed that a 1 degree Celsius elevation in the temperature around the Texas River led to a 19% increase in the dengue activity 18 weeks following that 1 degree in climate elevation, temperature elevation. But also with rising sea surface and changes in precipitation, we have an increase in the shellfish contamination with Vibrio vulnificus. This is a bacterium that's well known for causing diarrheal illnesses, but also for causing necrotizing fasciitis and severe skin and soft tissue infections following exposure to sea water. And also with increasing temperature and humidity, there is an increase in the length of some of the bacterial infection. For example, salmonella that we tend to see more in the summer. We have been seeing more and more salmonella cases even during the winter because of the elevated global temperatures. Another category that we need to keep in mind is the invasive fungal infections following climatic changes and natural disasters. For example, increasing temperatures make some fungi evolving what we call thermotolerance, and they gradually adapt to these higher temperatures. A classic example is the Candida auris, which has been evolving due to global warming and was initially restricted to very few countries, and over the past 10 years has spread all over the world. Wildfires and smoke also may be vector for dust-borne pathogens, such as Aspergillus species that have been cultured from wildfire smoke. And another risk for fungal infection due to climatic changes and natural disasters is the floods that lead to a damp environment that can lead to invasive fungal infections, such as the example of Aspergillus fumigatus meningitis that has been witnessed after the Indian Ocean tsunami. And when we think about fungal infections following disaster, we think about skin and soft tissue infections, and there are some examples listed here. One of the fungi, such as mucormycosis, that has been witnessed after the tornado in Missouri, but also respiratory infections, coccidiomycosis cases and outbreaks have been described after earthquakes in California. And also fungal infections can cause visceral infections such as peritonitis with a very unusual fungus called Bacillomyces varioti. So all this will make us think more about the infectious diseases complications of health that can be witnessed after natural disasters. So it is estimated that by mid-21st century, 37% increase in the risk of contracting dengue fever is projected. There is also a projection that 370% increase of heat-related death in general if the global mean temperature continued to rise just under 2 degrees Celsius, which seems to be the case. And 525 million additional people are expected to experience moderate to severe food insecurity due to heat waves by 2050. 2060. So let me talk now about the intersection between climate, conflict, and health. It's no surprise to anyone that our countries are really an area that have a lot of conflict. Over the years, we've witnessed a lot of colonial, civil wars, long-term conflicts. 14 countries have more than a third of the world refugees. It is estimated that by 2020 in the MENA region, we had 15.7 million internally displaced people. The majority of the internally displaced people came because of the armed conflict in several countries that are listed here, and the latest being what's going on in Palestine and Gaza. And if we look at the refugee camps, we know that these displaced populations, they have very dismal conditions of living, overcrowding, inadequate shelters, insufficient nutrient intake, poor vaccination coverage, and poor water sanitation. All this will significantly increase the risk of diseases. So the conflict exacerbates the climate change impact by three different factors: damaging of the infrastructure. This results in poor water, sanitation, and hygiene facilities. Displaced populations, as I mentioned, which increase the vulnerability to the climate hazards, and the overwhelming health systems, diminishing the scope for robust emergency response in the case of extreme weather events. They cannot deal with the challenges of the weather events when they are living under such poor conditions. More than 70% of the disease outbreaks that have been reported worldwide have occurred in fragile and conflict-affected settings. We cannot talk about conflict settings without talking about the damage of the water supply. This is one example of the Geneva Water Hub report that talks about how the water and sewage have been mixing in Gaza. And even when the war will stop, this mixage of water and sewage will have a tremendous effect on increasing the risk of infectious diseases for many, many years to come. And we cannot talk about the One Health approach to infectious diseases without worrying very much about this issue. So when we consider the intersection between climate, conflict, and health, with climate change, I mentioned we have rising temperatures, extreme weather events, worsened air quality, environmental degradation, increased allergens that exacerbate respiratory diseases. And on top of that comes the conflict that is an accelerator of climate change impact. With conflict, we have scarcity of resources, disrupted governance, more food insecurity, and weak institutional capacity. All this will have a tremendous effect with a negative impact on health outcomes as it relates to heat-related illnesses, infectious diseases, non-communicable diseases, worsening malnutrition, and mental health impact. It is estimated that 9 out of 10 countries with the highest number of people newly internally displaced by conflict in 2022 also experienced disaster-induced internal displacement, and 6 out of the 7 countries at risk for famine in 2022 were also affected by conflict. All the 6 are among the most vulnerable, and at the same time, they are the least ready to adapt to climate change. When we look at the effect of climate change on vulnerable populations, the most vulnerable to the climate change-related health impacts tend to be the people at the extremes of ages, whether children or elderly patients, those living in poverty, people with pre-existing chronic conditions, be it cancer, chronic kidney problem, chronic cardiac diseases, but also communities in geographically vulnerable locations, as well as mentioned, population in conflict setting. And the health profile of the population in conflict settings really increases their vulnerability to the impact of climate change due to several factors. The majority have low rates of vaccination coverage. They're exposed to food and nutrition insecurity. They have lack of access to proper water. They are more exposed to tropical diseases, particularly those due to vector-borne diseases. They have a higher experience of physical and psychological trauma, and they have lack of access to care for chronic conditions, including many medical conditions. And if we look at the case of Middle East North Africa region, this is a region that has endured tremendous conflict, as I mentioned, and that is no surprise to all of you. But also the region has been exposed to a lot of climate and natural disasters over the past several years. There have been a lot of problems. For example, Yemen, in addition to all the conflicts that are ongoing, they had also flooding. In Sudan, they've had floodings. But also there is water scarcity in the region, clean water scarcity. For example, Jordan and Egypt are among the most water scarce in the world. Iraq, Somalia, and Syria are experiencing more intense prolonged droughts, and this really has implications on the nutrition of the people. Palestine is also expected to see a temperature rise of around 4.4 degrees Celsius by 2100, which will significantly affect the water resources and increase the frequency of droughts. 12 of the 22 countries in the MENA region experience armed conflict. And so basically the region of the MENA exemplifies the intersection of climate change, conflict, and health, and how this will have a huge negative effect on the populations. The effective climate action in the region is hindered, as we know, by poor governance in the majority of the countries, a lack of the political will, and insufficient funding. And the most disturbing thing is that we don't have policies that apply at the regional level, where we have some policies in individual countries, in some of the wealthy countries in the region, but we don't have a regional policy that would take action. So what can we do to prepare for climate change impact on health? In 1988, the World Meteorological Organization and the United Nations Environmental Programme set up the Intergovernmental Panel on Climate Change, or IPCC, and the job was to advance scientific knowledge about climate change caused by human activities. However, with over 3 billion people living in places that are highly vulnerable to climate change, so far the action taken by the international community has really not been sufficient to prevent or to reverse the trends. So the international community of the Red Cross, or ICRC, it urged parties of the United Nations Framework Convention on Climate Change and the governing body of the Conference of Parties, or COP, to make 3 different commitments to ensure that people living under conflict are not left behind. And the first one was to accelerate and increase ambitions to cut the greenhouse gas emissions. The second was to acknowledge conflict-affected countries' high vulnerability to climate risk. And the third was to ensure climate action is strengthened and supported by fit-for-purpose accessible finance in countries enduring conflicts. How can we prepare for impact of climate change on health? We can do that by mitigation and adaptation. Examples of mitigation: we need to think about developing climate resilient healthcare system, reducing the human emission to achieve the Paris Agreement's long-term target of limiting global mean temperature increase to well below 2 degrees Celsius. Unfortunately, so far, I would say these efforts have not been successful, because it seems the projection are that we are getting to a 2 degrees Celsius an increase in the temperature. Sinking or artificially removing atmospheric greenhouse gas is another way for mitigation. What about adaptation? We can strengthen the climate resilient healthcare system, assess vulnerability and adaptation capacities, implement an evidence-based adaptation plan for health, and implementing health promoting intervention with early warning systems. One example would be, if we look at vector-borne diseases, we know that with climate change, we're going to expect an increase in vector-borne disease. So we establish a very active surveillance system for infectious disease that can warn us about the potential for having an increase in particular diseases. The dengue fever would be a good example for how can we survey for it and a plan for mitigation. The WHO has developed the climate resilient healthcare system framework. And as you see on this slide, the building blocks of the health system, it includes leadership and governance, health workforce, greenhouse gas emission. We need to look at climate research section, technologies and supply chain, and so on and so forth. And the way they define it is that a climate resilient health system should be capable of anticipating, responding to, coping with, recovering from, and adapting to climate-related shocks and stress. And the aim will be to bring sustained improvement in population health despite an unstable climate. And there is a role for research in this. What can we do in terms of research? We need to generate robust policy relevant evidence. This would be based on climate change, health vulnerability, and adaptation assessment. And the research can be either basic or applied research. It will translate field-based experience into research outputs and to plan mitigation. It will integrate research into policy to inform decision-making and to identify best practices to improve healthcare and emergency services in times of crisis. Research in conflict setting should be really an area where more attention needs to be put. Ongoing research is vital to understand the evolving impact of climate change on health and to develop intervention. And the effort should focus on identifying vulnerable population and to evaluate how to plan for adaptation strategies in conflict settings. However, as we know, we have many challenges in conflict areas, and the data is often very, very scarce. However, because we have so many countries under conflicts in our region, in the MENA region, there are many opportunities for conducting research in the area. And I would say that the region has really missed out on many opportunities to advance patient research. This is one example of an area that we were looking at recently, and that is antimicrobial resistance in the areas under conflicts in the Middle East. And we searched for data from Gaza, for example, and all we could find was a couple of papers on the very high rates of antimicrobial resistance in Gaza. And this was prior to the current war in Gaza. But without some baseline data on any particular health problem, I think it will be very difficult to plan for mitigation and adaptation. Research in conflict setting, I think the majority of the research related to climate changes and effect on health are currently being conducted in countries that tend to be the highest emitters of greenhouse gases. And these countries have the capabilities of planning for mitigation and for adaptation. The countries that are the most affected by these effects, and they have the highest number of vulnerable populations, have basically no data. And I think if we want to think about evidence, evidence requires research, research requires data, data is poor quality in this country or incomplete or totally absent in the setting of humanitarian contexts. Some of the NGOs have attempted to gather data from those countries. I mentioned Médecins Sans Frontières, MSF, or others, but unfortunately, still the amount of data available is insufficient. With that, I think I'm going to end my presentation. These are some of the references that we'll be happy to share with you, and I turn it back to Dr. El-Hadi. Thank you.
Thank you, Dr. Kench, for this very insightful presentation. We will now move to the next part. We'll be sharing our screen in a minute. Okay, so I'm going to start first by going with an overview about why we established the Center for Research and Education in the Oncology. So we believe that in conflict setting, there's a need to harness the field-based experiences of those working on the ground and translate them actually to research output, as Dr. Kench just mentioned, in order to mitigate the knowledge loss in conflict setting. Now, CREEW aims to strengthen humanitarian practice in conflict settings through contextualized research and tailored capacity building. Now, our CREEW outcomes are to translate these field-based experiences into research outputs and to counteract the effect of research and data poverty that is prevalent in the conflict-affected settings. One of the main activities of CREEW is a remote mentored fellowship program. And this fellowship program aimed to equip frontline health practitioners working in conflict settings with the necessary skills that would allow them to conduct research into the relationship between health and war. Now, the structure of our CREEW fellowship is over 3 phases, and this spans over 12 months. Every year, we have a particular theme. Now, the first phase is the didactic phase, and it follows an online modality that spans over 8 weeks. The second phase is a field-based mentored research phase, and this is where the research proposal is actually conducted in conflict-affected settings, and this goes over 32 weeks. The last and third phase is the research dissemination phase, and this is where fellows will finalize and submit their scholarly output that will span over 10 weeks. Every year, the CREEW Fellowship has had a particular theme that it tackles. So far, we've had 2 cohorts, one on antimicrobial resistance and one on cancer, both in conflict settings. We have graduated 8 fellows from 6 different countries, such as Jordan, Yemen, Palestine, Sudan, among others. This year, we have a scientific advisory committee that oversees the implementation process of CREEW Fellowship and a GHI team that coordinates and implements the program. This year, our SAC committee is co-chaired by Dr. Hassan Abu Sitta, who is the director of the Conflict Medicine Program at AUB GHI, and Dr. Soha Kench, who is the head of the infectious diseases, and she's been the speaker for today. Thank you so much again, Dr. Kench. Other members of the SAC committee include Dr. May Jordi, who is a professor and the chair of the Department of Environmental Health at AUB, Dr. Antoine Abou Fayyad, who is the assistant professor in the Department of Experiential Pathology, Immunology, and Microbiology at AUB, and Dr. Zahia Abdessadar, who is a senior advisor for partnership and innovation from AUB GH. From our end, I've introduced us already. We have Sarah Brahim, who is a program manager of the Epidemic and Pandemic Preparedness Program at GHI, and Dr. Adil Mdahli, who is the Associate Coordinator Officer at GHI, and myself, of course. As Dr. Kench mentioned, the 2025 CREEW Fellowship theme this year is to prepare for the impact of climate change on health in conflict settings. And this is through effectively building the research capacity of healthcare practitioners in those settings. So moving forward, I will go over the details of each phase. The first phase is the didactic phase, and this spans again over 8 weeks, effective October till end of November of this year. And during this phase, the selected fellows will complete a certificate in conflict medicine. Now, the certificate in conflict medicine is an online self-paced certificate to cater for the fellows' commitments, whether work, other life commitments, and it includes a series of 4 courses that are delivered on our online learning platform that we call the Global Health Learning and Development Platform. It includes 3 core courses and 1 elective course, where the learner can choose between either a specialty in infectious diseases or in detection and assessment. This will be run in parallel with a series of online workshops on key health topics that are essential to build the fellows' research capacity. We will address literature search and referencing, research conduct and ethics, of course, IRB submissions, and of course, scholarly writing and PowerPoint presentation. This didactic phase will be wrapped up with the fellows developing their proposal and completing the IRB submission. The second phase is the mentored research phase, and this will span from December 2024 till August 2025. And in this phase, the fellows will be matched with a mentor and a trainer assigned by GHI. This will enable the fellows to conduct their research in their respective conflict-affected settings. Key landmarks in this phase is for the fellow to meet online with his mentor on a monthly basis, meet online with their trainer on a bi-weekly basis, and implement the research proposal with the support of a locally identified mentor that we usually encourage from your home institution that will facilitate the process of identifying, gathering data, and collecting data. Every month, every other month, actually, the fellow is expected to write a report and submit the report to their mentors and their trainers. Next, we have the third and last phase, and this is the research dissemination phase. And here, the fellows are expected to finalize their manuscript, submit a final CREEW report, and only upon the completion of all of the CREEW fellowship phases will the fellow receive a certificate in conflict medicine and a CREEW certification. Next, we move to the application process. So to apply, first, you need to check the eligibility criteria, which we will discuss in a minute, prepare all the required documents, submit your application online on our website, and then we will reach to you with the answer. When it comes to the eligibility criteria, the CREEW Fellowship Program is designed for applicants who are health professionals that are interested in pursuing research work in conflict settings, obviously on this year's thematic topic. They are positioned to access and collect data, and they have the appropriate English proficiency that is consistent with the demands of the CREEW Fellowship, since the manuscript will be written in English. Next are the application requirements that include, first of all, a letter of intent. So the letter of intent should include a general description of your project, its significance to your home country or to the country of implementation, and how you expect to implement your proposed project and data collection given your current professional position. The personal statement should include your relevant academic and professional background, your experience in conflict settings, why you are applying to this fellowship, and how will it help you achieve your professional goals. So we have a letter of intent and a personal statement. Third requirement or third application requirement are recommendation letters. We need 2 recommendation letters from professionals who can reflect on your performance and how you are suitable as a fellow for the upcoming program. And finally, we require an updated CV following the template that we have on our website. This is a screenshot actually of what it looks like. You can visit our website for the details. And of course, we will be sending you a document that summarizes all the key information that we discussed today relevant to the application process. Now, key dates for you to remember are July 31st, and that's the application deadline. The first week of August, and that's when the SAC will conduct the interview for the shortlisted candidates. The second week of August, we expect to disseminate our decisions for those who were selected and those who were not. And the first week of October, this is where we will launch the first phase of our fellowship. Regarding the tuition fee, the CREEW Fellowship Program is a $5,000 fellowship that GHI is currently sponsoring. The sponsorship will cover the tuition fees, which include the costs of our online certificate in conflict medicine, our online training workshop, our mentorship fees, and the research costs. This brings us to the end of our discussion today, and I will leave the floor to questions. My colleague Hadil will be sending you in an email the document that I will refer to. It will include all of the key information related to the application process and how you can reach us as well. So if you have any questions, please feel free to send them in the chat box. You can drop your questions in the Q&A section, if there is any.
Nasreen, may I have a question?
Of course, please go ahead, Dr. Khan.
So my question is, other than by social media and on your own website, how are you advertising for this program?
We are sending emails to our network, to our GHI database. That's how we're reaching out to them. We have our mentors also, they're sharing that amongst their network. So this is one way of doing that. Okay, I have a question. Can you apply if you are an independent researcher? The answer to that is yes. Someone else? Okay, thank you, great. Any other questions? So I have a question. If we do not have access to region of interest to collect data, would GHI help facilitate access? So for this question, actually, it depends on your proposal, where you intend to implement it. So we have to study your actual proposed implementation plan. Biotechnology, I have another question. Are biotechnologists or life science students eligible for this? So as long as you have, you are a healthcare worker, and you have interest in applying to this topic, and you have appropriate plan to implement your project, then you would definitely be able to apply. Other questions? Looks like this is it. So thank you everyone for joining today. Thank you, Dr. Kanch, for your valuable time. Really appreciate it. Sorry, I have actually one more question before I wrap up. What about the topics? So, Hamad, the topics have to address the intersect between climate, health, and conflict. Okay.
Let me just, before you conclude, Nasreen, just to say that there is a wealth of data that needs to be collected. You know,
Yeah.
I think if we look at just I'm gonna take the aspect of infectious diseases because this is what I deal with. You know, over the past year or so, we've had outbreaks of hepatitis A, of cholera. We had in the past few years since the conflict started in Syria, we had an expansion of leishmaniasis spread from what used to be really restricted to Aleppo in Syria, to spreading in many areas in Syria, to reaching Lebanon, etc. I think what is lacking is for research to be done to collect the data so that we can have some meaningful data to plan for the future. So I think this program is really a wonderful initiative that can really support this.
Thank you very much. Thank you, Dr. Kavish. Thank you everyone for joining us, and we'll be available to answer any other questions. We will be reachable by email, and my colleagues will be sharing the documents with you for your reference. Thank you very much. Have a great day. Bye-bye.
Thank you. Bye-bye.